Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Okay, so now we're going to look at how to implement testing in practice. So establishing a pathway and having a multidisciplinary team is really important. As we've talked about throughout this hour, there are some complex issues that can arise, and we want to make sure we're performing appropriate testing on the appropriate patient. But I think we've maybe covered this fairly well up to this point.
Yeah, some of the tissues I would suggest maybe staying away from are FNAs, small amounts of tissue where there's not much tumor content. You would want to prefer those blocks or core biopsies where there's a large amount of tumor tissue. For example, when you look at each core, the amount of tumor content, the number of millimeters of cancer from the radical prostatectomy, you're going to want to send a higher risk area. A metastatic biopsy would be ideal. Some samples from bone metastases are going to be challenging because of decalcification and degradation. We also see issues with samples that are 10 or more years old, that almost half of those cases are degraded and don't give us a result. Doesn't mean you can't send those off, and if you get a helpful result, you can stop there. But if you don't, the reason may be because of degradation and lack of sufficient tumor content. So those are some of the challenges. Germline testing doesn't suffer from those results. You should be sending those on all of your patients. And a plasma test may be helpful as you're updating the situation of your patient, looking for additional acquired alterations that are in the tumor.
Yeah, so specifically addressing this question of are we doing the right testing? It looks like, as recently as 2018, 2020, a significant percentage of MCRPC patients were not undergoing testing. There had been an upward trend, but it's dropping off a little bit again now. So whereas right now the somatic results really only impact CRPC, there are a number of first-line MHSPC trials with PARP inhibitors. So we may need that information even earlier. So I think Andy's approach of testing all metastatic prostate cancer patients right away with somatic as well as germline testing may end up being important in the future.
One of the major barriers to genetic testing from that study was rural areas, being in a urology practice. Men of diverse backgrounds, Black men, Hispanic men, were less likely not only to receive these life-prolonging therapies, but less likely to get genetic testing in the first place. So I think, just asking, taking a good family history, doing the testing, referring to genetic counselors or to a comprehensive cancer center where the testing can be done would be a good step to reduce some of these disparities. Plasma testing can also help reduce disparities. It's instead of sticking a needle into a bone metastasis or a tumor or trying to track down a sample 10 years ago, a blood test can be done to identify these mutated fragments with either gene alterations, amplifications, or mutations in the plasma. There are challenges with plasma testing. You can't just order it when the patient's doing well and responding because the plasma ctDNA goes away. And there are actually algorithms. If you look at ctDNA.org, there's a nice mathematical model that can tell you whether, the probability of finding positive ctDNA that Alex Wyatt has developed. But basically, when the patient's progressing is the ideal time to do a ctDNA test. And that can find the exact same things that often are present in the tumor and can often find new actionable alterations in these DNA repair pathways that can help guide therapy.
Yeah, and as Andy alluded to, there can be some confounders in ctDNA, which include CHIP, clonal hematopoiesis of indeterminate potential. So this is really coming from the hematopoietic cells, which as people get older, prior smokers and men in particular can have certain white blood cells that just develop alterations. And so these can show up in a ctDNA test. And this leads to a little bit more nuance when we're interpreting the results of a ctDNA test. We want to make sure, something like JAK2 might stand out as, okay, that's probably CHIP and we're not going to act on it, but it can show up even in some of the genes that we're looking for that are potentially actionable.
And some of those genes are ATM and CHEK2, and I think we just told you that PARP inhibitors don't work as well in patients with ATM and CHEK2 alterations. Well, that might be because some of them are CHIP, but it could also be because some of them are monoallelic and not really drivers of PARP sensitivity in the first place. This was a remarkable study looking at the prevalence of CHIP in prostate cancer. You can see it's actually more common than not in our 80-year-old men. And it just increases in prevalence. And this study actually found that almost half of all the DNA repair alterations that were found in plasma testing were CHIP alterations, predominantly, again, in ATM and CHEK2, but not as common at all in BRCA2. So if you find a BRCA2, that's likely going to be real, but if you find a low prevalent ATM alteration, that may be CHIP, and having an orthogonal assay like tumor testing or a CHIP assay, a myeloid CHIP assay, can help rule that out and help avoid exposure to a potentially harmful or expensive and toxic medication.
So we only have a few minutes left. I won't go into too much detail, but Andy and I are part of this PROMISE consortium, which is more than a dozen academic sites pooling our genomic information linked to clinical data so that we can ask some interesting questions. And in this analysis, we looked at whether patients were getting serial testing. We've mentioned throughout the hour that you can have a cancer develop actionable alterations as it's being treated. And so serial NGS testing does have a role. And here what we found that 11% of second and beyond DNA sequencing, particularly with ctDNA, found new actionable data. So it's not insignificant. These are 11% of patients who would not have been able to be offered a PARP inhibitor or immune checkpoint inhibitor, and they could now be offered these treatments that could potentially really benefit them. So I encourage people, if you've had archival somatic testing on the prostate primary tissue, and now this patient's been through a couple lines of treatment, it's worth thinking about a ctDNA test to see if there's now something actionable.
And shout out to Joe Park, a fantastic Duke Oncology Fellow, for putting that together with our PROMISE team. And so here's a case of a 60-year-old African-American male presented with de novo metastatic hormone-sensitive prostate cancer, high volume, received ADT docetaxel, had a nice but transient PSA decline, now rising, no family history, but he was adopted. And so hopefully, again, this is not a difficult question. Would you perform somatic germline testing or both on this patient who's now progressing in the MCRPC setting? And the second question is basically the exact same patient, but what about if you find a CDK12 alteration? What therapeutic approach would you provide for this patient? Dr. Dorff, how would you answer this one?
Well, we saw in the FDA pooled analysis that CDK12 does predict for benefit from the combination in the combination studies, and this patient has only had docetaxel, so I would go with a PARP inhibitor combination with a
Me too.
AR pathway inhibitor. So here we have a 72-year-old man who has a family history of ovarian cancer on his mom's side, localized disease initially, but now recurrent with bone metastases. And the same question, somatic germline or both. And Andy, this patient had a BRCA2 mutation. I don't know if you want to talk about treatment, or again, I don't know if you want to go to the questions.
Well, maybe I could answer one of the questions I saw in the chat was, obviously this patient should be offered, an AR and PARP combination from the data that we've shown in the first line MCRPC setting. But in the hormone sensitive setting, we don't have any data. And so I would like to point out some clinical trials. We have the TALAPRO-3 trial, we have the Amplitude study, we have the EVOPAR trial, all testing AR PARP combinations. Amplitude and TALAPRO-3 are largely in the homologous repair deficient patients. EVOPAR is kind of a new PARP1 inhibitor that's being tested in combination with an AR inhibitor, both in HR deficient and non-deficient patients. So a little bit like PROPEL, but moving to the hormone sensitive spot. But in the chat, there was a question about, well, what if you gave a patient an AR inhibitor, then you discover the BRCA2 mutation? Should you switch AR inhibitors, like going from AbbVie to a Talipro-2 approach? And maybe Dr. Dorff, you could comment on, in your practice, whether you would extrapolate all the data that we've shown to a data-free zone.
Yeah, I think it's the real challenge of practice. The patients in Talipro-2 could have been exposed to AbbVie, although very few had been, but they could not have progressed on AbbVie. So technically, if the patient's progressing on it, then they wouldn't have qualified. You'd ideally be looking for clinical trials, and you'll get a lot of mileage out of single agent PARP inhibitor in this patient as well. So it's hard to make a compelling argument. We try to stick with the data. We recognize they're imperfect. I don't know if you feel any differently, Andy.
I agree with you. Sometimes you might have that discussion with the patient around risk benefits and the uncertainties and help them make a decision, and it's very personalized. But we would encourage clinical trial enrollment for those kind of questions, and there are some ongoing studies looking at second ARPI PARP combos now. So we're done. Here are concluding slides that I think you've heard that somatic and germline testing both are equally important for different reasons and complementary reasons to really help your patient in their family risk and counseling, but also in their personalized medicine approaches to living longer and better. That PARP inhibitors are an integral part of the treatment armamentarium, that many PARP inhibitors are now available, both as monotherapies and as combinations, making that individualized treatment decision with your patient on which AR inhibitor is right for them based on drug interactions, toxicities, which PARP inhibitor is right for them, again, based on the individual gene analyses, their comorbidities, their preferences, costs, and drug interactions, really part of the complex decision-making that we have to face. And hopefully you've heard from Dr. Dorff and I that molecular testing is the way to open the door to these discussions. Thanks for being with us today.
Thanks so much.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.